Bismillahirrahmanirrahim. Today we will talk about partial and total anomalous pulmonary venous drainage. This is PE, partial anomalous pulmonary venous drainage, and TA, total anomalous pulmonary venous drainage. Partial anomalous pulmonary venous drainage may be associated with sinus venosus ASD, right upper and middle pulmonary veins with superior vena cava type, and right lower pulmonary veins with inferior vena cava type. The point is, in the embryology, the sinus venosus received the pulmonary venous drainage and the SVC and the IVC in the same chamber. Then they get separated. So if this condition prevails after birth, so an ASD close to the sinus venosus may be associated with an ASD close, and a sinus venous ASD close to the superior vena cava may be associated with some of the pulmonary veins entering into the right atrium, and the sinus venosus related to the inferior vena cava may be associated with the lower pulmonary vein entering into the right atrium. For the total anomalous pulmonary venous drainage, there are 4 types. The point is, in the embryology also, the 4 pulmonary veins unite into one single vein that inserts into the atrium. But in this case, this single vein is absent. In the embryology, this single vein it fuses into the back of the left atrium, forming the posterior wall of the left atrium. And in this fusion or in this marsupialization, the pulmonary veins are included into the left atrium, and the final result is that the veins directly enter into the left atrium. But in this case, this common or this single pulmonary vein is absent, is atretic. So the pulmonary veins find no way to drain the blood in them. So the equilateral has to form, or equilateral has to dilate, so as this blood finds a way to drain. So according to the luck of the patient, or according to which collateral will dilate, if a collateral that is connected to the systemic pulmonary veins above the heart or superior to the heart, this forms a supracardiac type. So a collateral like this one enlarges and becomes the single, or the alternative single pulmonary vein that drains the lungs into one of the neck veins, or one of the veins, the tributaries of the superior vena cava. So in this case, the innominate vein, the right innominate, the left innominate. So this vein drains into the left innominate vein, and then into the superior vena cava, and then to the right side. In this case, the pulmonary veins find their way to the coronary sinus. So all the blood drains into the coronary sinus and then into the right atrium, which causes the coronary sinus to be enlarged. And you can see it in the echo. A large coronary sinus may suggest a total anomalous pulmonary venous drainage, or it also may suggest left superior vena cava, but in this case it is the cardiac type of total anomalous pulmonary venous drainage. If the veins find their path, or find their drainage towards the veins below the heart or subdiaphragmatic, so they may find a way towards the portal vein, the IVC, or one of its tributaries, the hepatic vein. So this is considered the infracardiac type. If one lung finds a way towards, for example, the upper, the supracardiac and the right lung finds its way to the cardiac, so this is considered a mixed type. So supracardiac, cardiac, infracardiac, and mixed. They may be associated with other cardiac anomalies, with the situs, may be associated with isomerism, whether left or polysplenia with left isomerism and asplenia with right isomerism. Scimitar syndrome is a total or partial anomalous pulmonary venous drainage of the right pulmonary vein to the IVC. Dextrocardia and hypoplasia of the right lung. So the heart is dextrocardiac. The right pulmonary veins drain to the IVC. The right pulmonary veins drain to the IVC. The heart is dextrocardiac with the hypoplasia of the right lung. In these patients, the descending vertical vein resembles a scimitar or a Turkish sword on a frontal chest radiograph. So it appears like a sword or a descending vein, like a sword entering into the IVC. Okay. Preoperative assessment, like the left to right shunt lesions. Anomalous pulmonary venous drainage cause left to right shunting during diastole with volume overload in the right side, like the ASD. History of low cardiac output, failure to thrive. In these cases are ASD dependent, which is very important. So the ASD should not be closed, and if for example an attempt to close it by a device in the cath lab may cause the patient to arrest on table. This mistake should not happen, because this ASD is right to left. So if the cardiologist finds an ASD with a right to left shunt in the echo, he should suspect this patient to be an ASD dependent or a total anomalous, or otherwise maybe it's an ASD with Eisenmenger syndrome. So such an ASD should not be closed. But anyway, if it is closed, it would be fatal. Assessment of other defects or congenital heart diseases. Degree of shunting depends on degree of anomalous drainage, whether it is partial, whether it is one vein, two veins, an entire lung, or both lungs, that it becomes total anomalous. The relative resistance of the vascular beds of the lung lobes, the relative compliance of the receiving chambers, the right atrium, left atrium, and vena cava. Preoperative pulmonary vasodilators are contraindicated in presence of distal obstruction, as they may increase congestion. Sometimes total anomalous is obstructed, so whether this supra or infra or whatever, it gets obstructed. Infracardiac types usually are obstructed. So obstruction in the pulmonary vein, in this single pulmonary venous drainage, causes pulmonary hypertension, and it is a surgical emergency. The patient should urgently go to surgery to relieve this obstruction, because the patient presents with severe pulmonary hypertension, severe lung congestion, pulmonary edema. So this should be addressed quickly. In these cases, we do not use pulmonary vasodilator, because the obstruction here is mechanical. So if I try to open the pulmonary veins and the pulmonary venous drainage, vasodilated, so more blood flows into the pulmonary circulation and congests more. So the congestion or the pulmonary edema increases with pulmonary vasodilators. The only solution is to relieve this mechanical obstruction by surgery. Total anomalous may be confused with intrinsic lung disease, as there is no cardiomegaly initially. Symptoms depend on degree of obstruction and the width of the ASD. A small PFO at birth causes severe obstruction, and it is a surgical emergency requiring intervention. Either balloon atrial valvoplasty, Rushkent, or total repair. May get obstructed, especially the subcardiac type, nearly all of them. So usually the subcardiac or the infracardiac type are obstructed. This causes severe pulmonary edema. A surgical emergency TE is relatively contraindicated in the supracardiac type, not to get obstructed, because maybe in this type, in the supracardiac type, if I insert a TE, the mass of the TE may increase the pressure in the superior mediastinum and compresses this single vein, which is a very important vein. If it gets compressed, it causes troubles. But if, for example, an innominate vein gets obstructed, it's not a big problem. There are the brain has another drainage on the other side. The arm may get swollen a little, but that's not a problem. But if I compress this ascending vein, that would be a problem. The right side may be hugely dilated with small non-compliant left side. And this may pose a problem during weaning. We'll talk about it later. So the right side may dilate hugely and the left side may get smaller and non-compliant, which renders total repair difficult. If the QPQS is more than 2 or obstructed, which is an emergency, partial anomalous, we reimplant, or we baffle, or do the Warden operation. We'll talk about it shortly. May need deep hypothermic circulatory arrest. In the supracardiac type, this is the ascending vein, so it collects the pulmonary veins and inserts into the innominate. So we ligate this ascending vein and take part of it. When it passes posterior to the left atrium, we open it to the posterior atrium. We make an incision at the posterior wall of the left atrium, and we connect the vein, the ascending vein, to this incision and suture them together. So the blood drains directly into the left atrium. In the cardiac type, we put a baffle that directs the blood draining from the coronary sinus into the right atrium. We direct it through an ASD or through the ASD to the left atrium. So blood draining from the lungs and blood draining from the coronaries get into this baffle and are directed through the ASD to the left side. And the blood draining the coronary circulation, as a percentage, it's a small percentage, so they do not cause any cyanosis. In the infracardiac type, it is similar to the supracardiac type. We ligate the descending vein, and we make an incision in both the left atrium and the vertical vein, and we connect them together, so the blood from the lungs drain into the left atrium. Post-TE, gradient across the vena cava and the pulmonary veins may get obstructed. Biventricular function, we check the biventricular function. Because all these sutures are close to the pulmonary veins or close to the vena cava, we should check the gradient across the vena cava and the pulmonary veins to detect any obstruction that should be relieved before getting out of OR. Biventricular function and estimated RVSP. Post-surgical, transferred to the ICU, intubated, ventilated after surgical closure. On-table extubation may be considered in mild partial anomalous pulmonary venous drainage, like in cases of ASD. Careful loading, because the left ventricle is not used to the increased preload and may fail, especially in previously obstructed cases. So inotropes may be considered. So the left ventricle is used to some blood coming from the right side through the ASD So when I do a total repair and the left ventricle gets surprised by a total venous return of the body, of the lungs, so it may fail. It may fail in diastolic heart failure. Persistent pulmonary hypertension is a major risk. Some systemic hypotension and pulmonary hypertension may be tolerated after bypass if the RV function is good and inodilators are used. Paradoxical pulmonary hypertension with systemic hypotension may occur with use of nitric oxide in patients with poorly compliant left ventricle. Because the problem in this case, the cause of the pulmonary hypertension is a poor left ventricular compliance. So further increasing the blood flow through the pulmonaries by a pulmonary vasodilator may increase the congestion in the lungs and further decrease the systemic hypotension. So pulmonary vasodilators are not indicated in these cases. Maybe a better choice is to increase the heart rate and to put inotropes, good inotropes. Dysrhythmias are common because of the dilated atria and the sutures in the atria. Now we'll talk about the AV canal, atrioventricular canal. The atrioventricular canal is seen as an ASD, a primum ASD, an inlet VSD, and a common atrioventricular valve, or a common mitral and tricuspid valve connected together as a single valve. So as if the central part of the heart has been taken out or eaten away or not developed. So imagine that this central part of the heart is absent. So an ASD, a VSD, and a common ventricle a common AV valve will result. This is called the endocardial cushion. This central tissue in the heart is called the endocardial cushion in the embryology, that later develops into the tissue that separates the mitral from the tricuspid, and a tissue that forms the septum primum and the membranous part of the ASD, of the interventricular septum. So this is the endocardial cushion that becomes absent or becomes atretic in these patients. This is the endocardial cushion. It forms valves that separate or ridges that separates the two AV valves, the left and right AV valves. So and then later this cushion forms the septal leaflet of the tricuspid and the anterior mitral leaflet. Those leaflets are called the mural leaflets, the anterior and posterior mural leaflets, and these are the lateral mural leaflets. So if this tissue is absent, so the original formation is preserved, the embryonic formation is preserved. An ASD, a VSD, and a common AV canal. This is the septum primum that then later becomes perforated, and this is the septum secundum, and the septum secundum contains the foramen ovale, and the foramen ovale and the perforation in the septum primum are not at the same level. So this malalignment forms the PFO, or the valvular formation of the PFO. So if this part is absent, so there will be an ASD primum. This is the common AV canal. And this is the superior endocardial cushion, inferior endocardial cushion. These are the mural leaflets. If these are absent, so a common AV canal will be preserved. This is the common AV canal. These are the types of common AV canal. If there is some separation, so if there is a separation and an ASD primum, this is called partial AV canal with an absence of a VSD. This is called partial AV canal. And sometimes the anterior mitral leaflet of becomes clefted, so there is an ASD primum and a cleft in the anterior mitral leaflet causing regurg. Transitional AV canal is the same but with a restrictive VSD. The complete AV canal is what we were talking about, a common AV valve, an ASD primum and an inlet VSD. The unbalanced AV canal is the same but with a small ventricle, either left or right, causing the case to be managed as a single ventricle. Maybe associated or it's common to be associated with Down syndrome, also Noonan and Ellis van Creveld syndrome. Preoperative assessment, like the general considerations for left-right shunt, a baseline saturation. Cyanosis may be caused by either bad chest condition and congestion or by pulmonary hypertension. So a common AV canal with a low saturation may be severe pulmonary hypertension or a very bad chest condition due to congestion. History of low cardiac output, failure to thrive, assessment of other defects and congenital heart disease, severity of congestive heart failure depends on the ratio of pulmonary and systemic vascular resistance plus the degree of AV valve regurg. Signs of pulmonary hypertension development, they occur within 1 year. It's most severe in the common AV canal, and then the transient, and then the partial. This is the cadaveric view of the, or maybe no, it's a cadaveric view. This is the cleft, and this is the common AV canal. This is the mitral tricuspid. So this is this is the tricuspid, and this is the mitral, the left and the right, and this is the cleft, and this is the site of suturing. They suture this line to separate the right from the left. Sutures here to separate the right from the left. Then they put an ASD patch, an inlet VSD patch, and they close the cleft. If unbalanced AV canal, a single ventricle management. So this is the common AV canal. They suture the anterior and posterior mural leaflets together, and they put a patch in the ASD and the VSD, and sometimes it is a single patch transcending the two defects. TE view, left and right AV valve regurg, and we try to diagnose whether the regurg is due to the cleft or the regurg is lateral. A regurg in the cleft is easily to manage. Suturing the clefts together will solve the problem. But if the regurg is lateral, so possibly it will not be solved. Another thing should be done, like repair of the leaflets or annuloplasty or things like that. We visualize the cleft, the left mural leaflet size and the interpapillary distance. The less the distance, the more likely left AV valve stenosis occurs. So this is a good form. The papillary muscles are wide apart, and the left mural leaflet is large. So if I close this cleft, an orifice, a good orifice will remain. So I solve the problem of the regurg without causing stenosis. But in this case, closing the cleft and solving the problem of the regurg may result in stenosis. This is a partial AV canal. Only an ASD is here. Maybe there is a cleft here. Yeah, there is a cleft. This is left AV valve regurg from a cleft, and it is obvious that the regurg is closer to the septum, so it is inside. The regurg is through the anterior mitral leaflet, so this is a cleft. It is not lateral, it's median. This is a cleft regurg. So this is a basal view, the mitral valve opening and closing in a short axis, and the tricuspid valve opening and closing in a short axis. And this is the cleft, and the regurg is here. Can you see this line of regurg? So closing this line will solve the problem and stop the regurg. This is also a cleft regurg. Post repair, after closing the cleft, this is post repair. There is no regurg, maybe some residual right AV valve regurg. This is also post repair. You can see here, this is the sutures of the cleft. These are the white line are the sutures closing the cleft. This is stenosis. This is a long axis view, left atrium, left ventricle, mitral, and aorta. So after repair, there is stenosis. High possibility of AV conduction abnormalities up to permanent complete heart block, especially in common AV canal, because the bundle passes close to the inlet VSD. Transfer to ICU intubated after surgical closure on table extubation may be considered, but usually not. We checked by TE the biventricular function, the estimated RVSP, left and right AV valve regurg, gradient across both AV valves, residual across the ESD patch and the inlet VSD patch if present. We'll talk about this in the next lecture. Thank you.